Diabetes mellitus is a group of syndromes characterized by the presence of chronic hyperglycemia, to which, in general, a set of vascular and systemic complications are associated in varying degrees. It is a frequent disease, of increasing prevalence in all countries, which entails high morbidity and mortality. It appears grouped in several syndromes. In type 1 diabetes, the virtual disappearance of the beta cells of the pancreas responsible for producing insulin can be seen at the time of diagnosis. It usually appears before the age of 30, but can manifest itself at any age. Biologically, it is characterized by insulinopenia, which determines the clinical picture and its treatment. Type 2 diabetes is much more frequent and, in general, of later onset. It is usually associated with obesity, diabetes not dependent on insulin. In this group of syndromes, the pancreas secretes very variable amounts of insulin, so that its plasma concentration may be normal or even higher than normal, but relatively insufficient to maintain normal blood glucose levels. This indicates that in type 2 there may be a resistance to the action of insulin. That is, an excessive hepatic glucose production and poor peripheral utilization despite the presence of insulin. So that we can be speaking of a relative deficiency in the pancreatic secretion of the hormone. Insulin is the therapeutics of most of the patients with diabetes type 1, and of many with type 2, when it is needed. The insulin can be administered by intravenous or intramuscular route. Anyway, the long-term treatment is based in a predominant way in the injection of the hormone for subcutaneous route. The insulin preparations qualify in accordance with the duration of its action: short, intermediate, and long, and according to the origin species, human or porcine. The insulin human is extensively available like result of its production by means of DNA recombinant skills. The porcine insulin differs from the human one for an amino acid alanine instead of treponine in the terminal carboxylo of the chain B. This is in the position B30. Taking into consideration that the rats were in fasting, the basal glucose ranges between 87–140 mg/dl. With the results of the practice, we can conclude that in the problem 1 endures the blood glucose as it was expected. During the first 30 minutes the values are raised and they descend later to the insulin application, returning to basal values after 45 minutes. The problem 3 presents the classic behavior of the concentration of blood glucose in diabetic patients whose treatment is the administration of insulin before to the ingestion of food. The glucose in blood increases, but not in a way as drastic as in case of the problem 1. Therefore, we conclude that the insulin stimulated the glucose transport, on having favored the translocation dependent on energy of vesicles intracellularase that the carriers of glucose LUG4 and LUG1 contain towards the plasmatic membrane. And that obtain better results WH. Then, the insulin is administered before receiving the glucose load. The problem 2 and 4 shows us a typical case that can go so far as to appear in our society: the administration of insulin without this one being needed, which takes the state hypoglycemico, one of the most frequent reactions of the administration of insulin. Many diabetics consume less quantities of food of those who have been planned originally. Such a situation, in the presence of an already injected dose of insulin calculated with base in a meal of major magnitude, might result in hypoglycemia postprandial, due to an excess, both absolute and relative, from the administered insulin. The 2-1 change is understood by relative excess in the habits of the patient who unbalances the relation dose of insulin/glycemia, previously established. To avoid a hypoglycemia, it is necessary to educate the diabetic on the needs and actions of the insulin, and to alert it on symptoms typical that can come to convulsion and coma.